Good evening, everyone, and thank you so much for joining this webinar on the perimenopause. I'm going to be recording it so that you can watch again or we can share with others, and feel free to forward on to friends if you think it would be helpful. We are going to have an opportunity at the end for questions, which will be shared in the Q&A function in the toolbar. But be assured I won't identify you, so feel free to ask questions. However, it's worth noting that if it's a specific clinical question, then I'm not going to be able to answer, but I will do my best to answer the general ones. So do post your questions as mentioned, but let's get started. So for those of you that don't know Remedy Health, this is a little bit about us. My name is Deborah Evans. I'm the clinic owner, started the clinic about 18 months ago. I'm a mother of 4, grandmother of 3, and I've been a pharmacist for coming up to 37 years. And I guess important for this evening is I have definitely been perimenopausal, and I would like to say I'm out the other side, but I think it's a continuum, but more of that later. So Remedy Health is an independent business. We have a single unit here in Winchester in Hampshire, and we are a private pharmacy. In other words, we are registered with the General Pharmaceutical Council, but we don't have an NHS contract. But we do offer a range of clinical services. We're always available for accessible advice. We do diagnostic testing, bloods, for example, and a range of treatments. And really our philosophy is around giving people the best opportunity to take control of their own health. We follow very much an evidence-based practice, and we do have independent prescribers on site. We're led by pharmacists, but we do engage with a wide range of other healthcare professionals, and we do link into other healthcare providers. We pride ourselves on being able to refer in to appropriate people or to be able to refer you on for other investigations if you need it. As a pharmacy, it's really important to us that we can provide and supply medicines on site. And importantly, given the supply chain issues for HRT, we pride ourselves on doing our very best to get hold of it for the women under our care and those who access our services. So whilst we can't achieve the impossible, and it has felt pretty impossible at times, we do our best to offer alternatives and to keep everybody informed and involved. Now, we do love seeing people in our beautiful clinic here face to face, but we do also offer remote consultations for those of you that are a little bit further afield from Winchester. So let's get on to this evening's topic. We are covering the perimenopause specifically. The first in our series was a more general overview around the whole menopause. So we will be covering similar content to a point, but I want to get a bit deeper into the perimenopausal, particularly those of you listening in who are perhaps younger and wondering what this is all about, or thinking you might be starting and entering the perimenopause. So important questions that we'll cover is: how will I know I'm in the perimenopause? How do we diagnose the perimenopause? When does it start? When does it end? But we're also going to cover situations where an early menopause, an early entry into the perimenopause might happen, either surgically, medically, or just naturally. We're going to cover off fertility and contraception. It's an important thing to consider during the perimenopause, and importantly, treatment options, including HRT. And of course, as I mentioned, there will be opportunity for some questions. So just to make sure we're really clear about the terminology, I want to really outline the different stages to menopause. And whilst everyone's experience of the menopause is their own, and it doesn't feel as we're going on the journey that we're specifically labeling stages, and we know that, you know, in March we were in the perimenopause and April we were in the menopause. It's a journey, and it's also something we look at kind of more retrospectively, because you don't know when your last period is your last period, and we'll come on to that. So just to have a look at this particular slide, the ages here are guidelines. They're most people's experience, and it's worth noting that the age at which we go through these stages can vary considerably, earlier or later, and more of that as we go through. So premenopause is that stage in our lives before any menopausal symptoms occur. It's the period between puberty and generally our mid-40s. We may experience symptoms related to the hormonal changes, but they're linked to the monthly cycle, or it may be during pregnancy or in that postnatal period. So we're probably preoccupied with lots of different things concerned with having periods, whether we want to get pregnant or trying to not get pregnant, but it is, generally speaking, for most women, a reproductive phase. The perimenopause, the focus for this evening, is that period, usually around about our mid-40s, when we're experiencing symptoms due to hormonal changes, and they can be quite insidious, they can creep up on us, they can be attributed to many other situations and potentially conditions. But we are still menstruating. It might be very patchy, and we'll talk about the changes to our periods. But it's also important to note that if you're using hormonal contraception or have a Mirena in situ, then periods are not necessarily a signal. And so you can start to have strange and perhaps sometimes really quite odd symptoms, which you may not attribute to this period in your life. So we're going to go through that in a lot more detail. The menopause is that point in time when we haven't had a period for 12 consecutive months. Certainly my own experience was that I really wasn't sure what the last period was. I'd really got very tired of even bothering to note them. I wasn't trying to get pregnant, and I wasn't trying not to get pregnant. It was just an age where I really wasn't that bothered with my periods, and they might turn up at very odd stages. Maybe 2 or 3 months would go and I wouldn't have one. And in fact, I remember having almost a year without one. And then I had a bleed. So it's very difficult to know that last period unless you're tracking. Postmenopause, well, that's the rest of the time in your life after your menopause, after that point in time when you've not had a period for 12 months. Now, we often talk about being menopausal. It almost becomes a verb. And so the term menopause tends to perhaps describe any of this period from perimenopause through to postmenopause. So let's not get hung up about the terms, but from a medical point of view, the perimenopause is this period that we're going to focus on from the very first start of having menopausal symptoms through to when you reach the menopause 12 months after that last period. Now, for some of us, the perimenopause can last for many years, and I think the average is probably about 7, but it does vary considerably, and it very much depends on the severity of your symptoms and how much you note in terms of that period. Looking at that timeline again, it generally begins in the early to mid-40s, and it's usually a time when we're super busy with jobs, family, life. We might have children who are becoming teenagers, young adults themselves, or indeed looking after older parents and relatives. So it can be a time when it's very difficult to spend time thinking about ourselves, looking after ourselves, and really noting what's happening. So it'd be fair to say that if you come into the clinic here at Remedy Health, if you're in your late 30s and above, we're really tuned in to the perimenopausal symptoms. So we will ask you about your periods and symptoms for almost any presenting complaint. And you'll see from the range of symptoms that can be experienced that it perhaps might become more normal during 40s in particular, for doctors to ask that question when you visit them. So what's happening to our bodies during this time? Well, it starts with our ovaries. We produce around 500 mature eggs during our lifetime, but we start off with many, many more potential eggs. So at birth, there are about 2 million. It reaches and reduces to 400,000 by the time of adolescence. I don't know who's counting these eggs, but it certainly declines as time goes on. Our fertility peaks between our late teens and early 30s. And by the age of 35, we roughly have around 25,000 of these potential eggs left. And by the time we reach the average age of menopause at 51, we have fewer than 1,000 eggs left. And of course, we know that very few of those will actually mature, if any. Now, importantly, when the egg supplies reduce, our hormones fall. And when our hormones fluctuate and fall, particularly estrogen, then symptoms occur. Now, we're going to go through this in more detail, but it's important to note that the hormone fluctuation occurs during the perimenopause is such that it really can be lower one day and high the next. And that accounts for some of the very difficult challenges that some women go through. Now, if we just really hone in on our reproductive organs, particularly our uterus and ovaries, you'll see here in this picture that our ovaries have these decreasing egg reserves that we talked about. Our estrogen decreases, and then ovulation becomes irregular, and that's why our periods start to falter. We might go a month or two between periods above our usual interval, and indeed we might have periods more frequently. Then importantly, the hormones from our brain, and this was covered in our first webinar, including follicle stimulating hormone, are trying really hard to stimulate the ovaries to produce estrogen. So by the time we become postmenopausal, very little estrogen is now released, and our follicle stimulating hormone is the one that's really trying hard and increases in concentration around the body to try and stimulate the ovaries, which of course are basically faltering and eventually stop producing and releasing eggs from those ovaries. So when we look at that in terms of a graph, a woman's life in hormones, we love this graph in clinic because it gives us the opportunity, particularly looking at the estrogen level, which is the top line, to show just how estrogen declines over time. And if you look at that sort of really erratic pattern, that's the perimenopause, that period from our early to mid 40s when our estrogen can fluctuate widely. And that accounts for many of those difficult symptoms. Once we get to the menopause, you'll see that our estrogen levels are low, and that too can lead to symptoms. So having an estrogen deficiency, a hormone deficiency, just like any other hormone deficiency, will lead to changes in the body. You'll see also from this graph that other hormones are declining as well. Progesterone and estrogens are very intimately linked, and so that declines. From a sort of biologically active perspective, our testosterone is also declining, and it is a female hormone. It is an important hormone for us, and decrease in testosterone can particularly lead to difficulties in cognitive function, memory, brain fog. And we do have a webinar at the end of this series, which is all about testosterone. But what do these fluctuations mean? Well, some women may not get any symptoms or barely notice any, or certainly not attribute the symptoms that they've got to the perimenopause, whilst others are really struck with very severe symptoms for many months or even years. And it is entirely a unique experience. And really humbled by the stories that I hear from many of the women visiting our clinic in terms of how they are experiencing this period and some of those really very difficult challenges that they might have physically, emotionally, mentally with those symptoms. I know for my own part, the perimenopause was an incredibly difficult time. I had very heavy bleeding and very difficult periods to manage. But psychologically, for the first time ever, I experienced very high levels of anxiety. But in fact, funnily enough, it was joint pain and aches that prompted me to seek support with hormone replacement therapy. So our journeys are very, very different. So I want to talk a little bit about when menopause happens outside those sort of normal ages and what we mean by early menopause. So if you go through menopause between the ages of 40 to 45, so that's defined as this year post your last period, it is known as an early menopause, and it affects about 5% of the population. So if you think that a perimenopause can last several years, 7 or 8 years, then actually these women that are going through an early menopause, so 1 in 20, will start to experience perimenopausal symptoms in that period from sort of mid-30s onwards. So we need to be alert to that. And the range of symptoms are the same as menopause at a normal age, only we may not be expecting it, and it's easy to miss and blame on other conditions. So we would recommend that women of all ages use a period tracker to monitor what's happening to them, and also link that into symptoms. There's a condition called premature ovarian insufficiency, or POI, which is defined as women that sort of have ovaries that are no longer functioning as they should before the age of 40. So again, this affects a significant number of women, about 1 in 100 women under 40. 1 in 1,000 women under 30 will go into premature ovarian insufficiency, and about 1 in 10,000 under 20. So it is something that can happen. It can happen abruptly or gradually, but again, we need to be alert to that being a particular issue. Now, other reasons for entering an earlier menopause are surgical and a medical menopause, and this can happen for a number of reasons. Medical treatment, this could be due to drugs given to women who've had breast cancer, or surgical removal of the ovaries, for example, cysts and endometriosis, radiotherapy in the pelvic area, and some drugs which may have been given for earlier cancers in somebody's life, not related necessarily to reproductive cancer. If both ovaries are removed, then an individual will become menopausal immediately, and having the womb removed, even if the ovaries are not removed, could still result in an early menopause, or POI, premature ovarian insufficiency. Up to 50% of women who have a hysterectomy but with ovaries remaining intact will menopause, and it's not clear why this happens, but again, it's important to watch out for. And then there are other conditions such as autoimmune disease, such as Addison's disease, thyroid disease, celiac, which can be linked to an earlier menopause, and notwithstanding genetic conditions. So an early menopause can run in families, although premature ovarian insufficiency is not inherited, but it is worth knowing how your mother menopaused if you're able to find out that information. So one of the key questions for women in their late 30s, early 40s is, am I in perimenopause? And so it's important to understand how you might tell. So it's very common to experience these symptoms at some point during this period. And as we've mentioned, the severity varies tremendously. Some of the symptoms can be really quite difficult to pin onto hormones for individuals. And so we do find individuals presenting at their doctor for a number of different conditions, and being then referred on, for example, to cardiology or psychiatry, when actually it might be a hormonal issue. So some women, as we've mentioned, may only experience symptoms for a few months. Others might be for years, even decades. And 1 in 4 women will have very severe symptoms. These are symptoms that are in fact impacting their ability to live a normal life. And when you think that over 50% of the population is female, and all women or people born with a uterus will go through the menopause, this is a significant issue for society, for families, for individuals, and in the workplace. So let's first of all talk about the changes to periods. So they may get longer, shorter, heavier, lighter, stop and start. They can be erratic. Generally, they will change. So what is change for you? And this is because, as we've mentioned, your estrogen levels are changing. Your ovaries may not release an egg as regularly as they used to. And if you're not releasing an egg, if you're not ovulating, you won't go on to have a period. But as mentioned, if you have a Mirena coil in place or other hormonal contraception, then it's going to be very difficult to know whether you're in the perimenopause, or you'll have to go by other symptoms. Now, we also are very mindful that if heavy bleeding occurs, for example, or bleeding after intercourse, there are other reasons why that might happen. It may not just be hormonal. So we do need to make sure that we're listening out for any sort of red flags, anything that might indicate a structural cause, such as fibroids or polyps, or any other issues that need addressing. So it is important, if you are having unscheduled bleeding or anything that's concerning you that's not normal for you, that you do engage with your healthcare professional. For many people, it's not a cause for concern, but we do need to check it out. Now, let's talk a little bit about premenstrual syndrome, PMS. So what we do know from studies is that premenstrual syndrome sufferers are twice as likely to experience mood swings and hot flushes in the perimenopause. So it might be an indicator that you may experience worse symptoms during the perimenopause. But having said that, somebody that hasn't experienced premenstrual tension and syndrome can go on to have bad perimenopausal symptoms. So it's just really an indicator of what you might expect. But as you're going into the perimenopause, you might notice a shift and a change in your PMS. Your mood changes and breast tenderness, for example, may become more severe. So let's go through some of the physical symptoms of the perimenopause, because they are wide-reaching, and you'll see by this chart on the right-hand side that they can affect pretty much every body system. So you have estrogen receptors in pretty much every part of your body, and these low levels and fluctuating levels during the perimenopausal period can then lead on to these weird and not so wonderful symptoms. And it can include things such as bad breath, burning tongue, heart palpitations, as well as the more sort of recognized symptoms. So we use various trackers and questions during a consultation to establish what's going on. But just to sort of summarize some of the key symptoms, abdominal pain and other gastrointestinal symptoms can occur during the perimenopause if they haven't been there before, or they can worsen. And frequently women present with IBS, perhaps for the first time, or worsening IBS during this period. Bloating, wind, constipation, diarrhea. Essentially, the gut is very sensitive to changing levels of those hormones. And in addition, declining estrogen can impact on stress hormones, which also have an important part in gut motility. Breast tenderness, estrogen can cause our breasts to change, whether stimulating the breast ducts to enlarge, or if we've got low levels of estrogen, causing them to shrink and not be as full as they were before. But of course, if you notice any changes that are concerning you, pain, fever, lumps, bumps, nipple discharge, changing shapes, dimpling, etc., then again, that needs to be checked out. Other symptoms can include nails breaking, dry skin, dry eyes, really sort of sore, dry eyes. We see a wide range of skin problems, including things like acne, rosacea during the perimenopause period. Again, estrogen levels can affect collagen production, and this can lead to particularly fine lines, dryness, itching, tingling. And in fact, actually, women, you can really see the difference in skin between women that are on HRT and not on HRT because of the effects of low estrogen on the skin. Some women notice they get increased facial hair growth, dry mouth, gum disease, oral health problems, this burning tongue, heart palpitations. The list goes on, doesn't it? I mean, there are probably around 50 different symptoms attributable to this period in a woman's life. And certainly one of the main complaints that we hear about is not being able to lose weight. And again, we know estrogen affects our metabolism. And in fact, low estrogen can lead to metabolic disorders, including an increased risk of type 2 diabetes. I mentioned joint and muscle pain earlier. This is usually more common in the mornings because estrogen tends to be at its lowest first thing in the morning. And it's an important hormone in providing lubrication for our joints and preventing inflammation. So I just felt like I'd worked out beyond anything I'd ever worked out, and that was pretty constant. Now, migraines are generally worse during the perimenopause compared to when you come out the other end. This is usually because of the changing hormone levels. And so if you do suffer from migraines, you might find that they become more severe or closer together during that perimenopausal period. Now, you'll notice I've not mentioned hot flushes or night sweats yet, and yet we know it's the most recognizable menopausal symptoms. And quite often we'll have women talk to us about, well, I've not had a night sweat, so I think, you know, I'm pretty much through the perimenopause and I'm absolutely fine. But then when we dig a bit deeper, all of these other symptoms come to the fore. Around 70% of women will have hot flushes and night sweats. And actually, for those of you that do have them, should you choose to go on HRT, the return of night sweats and hot flushes it tends to be quite a good indicator that you might need a bit more estrogen replacement. It does affect, as we said, about 3 out of 4 women. They can come on suddenly at any time of day, spreading throughout your face, chest and body, really quite unpleasant. And they can be a sign or a cause of waking up in the middle of the night or early in the morning. And so disrupt sleep. And if you're sleeping with someone, their sleep too. So I think I've touched on quite a lot of the symptoms there. And as I mentioned earlier, some of those will lead to referrals to perhaps rheumatology, for blood tests to check for autoimmune diseases, and to cardiologists when actually they are probably most likely attributable to the perimenopause. The other symptoms that we can get, they tend to come later on, but can affect women in their perimenopausal period, are the genital urinary symptoms of this period. So low estrogen can cause the tissues around the vagina and vulva to become very dry, itchy and inflamed. Everything just becomes less plump, for want of a better word. Atrophy is the word that's been used before. It's such a really horrible word. But the reality is that just as our skin on the outside gets drier and thinner and loses collagen, our vaginas and vulvas also lose tone. Now, it doesn't just affect sort of dryness. It can become an environment where bugs can grow, so our sort of natural flora can change. In fact, we can be more prone to infection, and not just things like thrush, but also UTIs. So particularly in older women who are having frequent UTIs, vaginal estrogen can really help, but it also can improve tone for those people that feel they've got problems with their pelvic floor. Yes, they absolutely need to do pelvic floor exercises, but actually we need the tone given by estrogen in that area, and it's easily addressed, and we are actually covering that in the next session to talk about genital urinary syndrome of the menopause in a bit more detail. I want to now talk about the psychological and cognitive issues associated with the menopause, wide-ranging, and I'm going to talk a little bit more about why that's the case in a moment. But the sorts of things that can happen during this period are depression. So if you've been prone to depression in the past, that can worsen significantly, or it may be that you've never been depressed or feel you've been depressed, and yet you feel yourself plummeting into a really dark place. Anxiety, really not feeling like yourself. We hear a lot from women who have lost confidence in themselves, not able to do the things that they previously have just breezed through. Women who've left jobs and roles because they just don't feel that they have a worthy place in those jobs. It's incredibly sad to hear some of the stories. So that's a very, in fact, actually all too common in terms of the impact that the perimenopause and menopause can have on women. Brain fog, which is a collective term for those memory slips, poor concentration, difficulty in absorbing information, feeling like your brain is cotton wool, really good sort of chemical and neurotransmitter reason for that, but it is a big feature. We kind of tend to joke about it, but it's not funny when you're trying to run a meeting or do something and you just completely lose the word. Other neurological pathways can mean that we have an altered sense of taste and smell. We might have hearing issues. Tinnitus is not uncommon. The effects in our neuropathways can create low libido and can reduce our pleasure from sex and intimacy. We might not have as an intense an orgasm, for example, just, that associated with vaginal dryness and feeling pretty rubbish, not getting good sleep, for example, doesn't, lead to wanting perhaps to have a very active sex life. We're going to talk about testosterone later on in the series, but it does play an important role in regulating libido. But it is more than just testosterone. Estrogen needs to be optimized too. So this whole area of psychological and cognitive function associated with the perimenopause is really important and can lead to fatigue, poor sleep, and just generally feeling low motivation to do all the things we know we want to do and perhaps to look after ourselves. And I just want to share with you this particular chart on the slide now, which shows the blue is female and females on antidepressants by age group. And you can see there that the highest number of prescriptions for antidepressants are prescribed in women, point number 1. The blue is bigger than the brown, and the highest numbers is in women aged 50 to 59. It's also a period of life where women are at most risk of taking their own lives. And I don't think it's any coincidence that this is the period that we're going through, the perimenopause, and a significant change in our lives. And I want to just take a time to sort of reflect on what's happening. So in science and medicine, we tend to separate out the mind and the body. However, the brain is an important organ and it's intimately linked with everything else physically in our body. And it's supported by a massive range of chemicals and neurotransmitters and hormones. And yet we tend to think about the menopause as what our wombs are doing, our ovaries and reproductive hormones. And in fact, I started the presentation there. But actually, estrogen in particular, and estrogen is more than one hormone, it's a complex interplay of hormones, is a highly biologically active hormone that has a huge impact on our brains. Progesterone and testosterone are also very potent neurosteroids. So if we think about estrogen in more detail here, it's actually known as one of nature's psychoprotections. It's a hormone, and particularly 17-beta-estradiol, which is our most biologically active hormone and the one that we replace with many of our HRT treatments, does go into the brain and has many receptors that it works on in different parts of the brain. It also has an important role in working with some of our other neurotransmitters, such as serotonin and dopamine. Has quite a potent effect on how those hormones, how those neurotransmitters are translated in the body and how they have their effect. So without going into sort of too much science, it's the important message here is that estrogen has a direct effect on many aspects of our brains, but it also has an effect on our neurocircuits and also our other neurotransmitters. And here we've got on the left antidepressants, serotonin reuptake inhibitors, being prescribed to women in their 50s, women that are going through the perimenopause and menopause, to address potentially many of the psychological impacts of low estrogen, and yet we have an opportunity to replace estrogen. So the other thing to say is that if you go on to an antidepressant, an SSRI, it can increase levels of a hormone called prolactin, and that in itself can decrease your follicle stimulating hormone, and that therefore decreases the level of estrogen. So you can accelerate some of the symptoms and impact of the menopause. So it's a really intimate relationship. If you are on an SSRI, don't stop taking it, because the withdrawal can be awful. So you do need to talk to your healthcare professional. If you're not on HRT and you are on SSRI, we know that estrogen can help in many ways, not only directly on the brain, but it can also support the use of SSRIs. So lots to think about. It's an expanding area. It's not moving fast enough for many practitioners, but there is some work undergoing in this country, led by Louise Newson's group, working with a psychiatrist in Australia. Here, Professor Jayashri Kulkarni, listened to a great podcast from her, and she's developed a menopause D questionnaire, which certainly we can give you access to if you'd like to understand more about that. So let's now talk about how we diagnose the menopause. Here's the official diagnosis from NICE. It essentially says we don't need laboratory tests in otherwise healthy women aged over 45 with menopause symptoms. It's based on vasomotor symptoms and irregular periods, according to NICE. We know it's much more than the hot flushes and night sweats that are defined here. And the menopause itself is defined as those that have not had a period for at least 12 months, as we've talked about. So it does talk about blood tests, and using a follicle stimulating hormone blood test is only advocating in the guidelines for women for 40 to 45 with symptoms and a change in cycle, and for those under 40 years. In practice, FSH tests are not that easy to interpret during this phase, and we tend to go more on your symptoms and any changes to periods. NICE goes on to give a whole list of things not to test for during this period, so that's something to discuss with your healthcare professional. But I know a lot of women want to have blood tests to know where they are, but given the fluctuations in hormones, it's just not very informative. We use blood tests for other reasons during this time, particularly for women to check absorption of their HRT if there's any question about that, and if women are starting testosterone. For us, diagnosing perimenopause here in the clinic, we take a good history because, as you can see from what we've talked about already, it's about periods, it's about symptoms, it's about understanding whether there are any other health issues or conditions that we need to be aware of and to think about, and to understand family history. Blood tests can be helpful, but usually to exclude other problems such as thyroid dysfunction or deficiencies of some vitamins or anemia, for example. So, put very simply, if you're over 45 and have noticed changes to your periods and have started getting any of these symptoms, then healthcare professionals should be able to diagnose your perimenopause without the need of any tests. And if you're under 45 and you're not having periods because of your contraceptive method or underlying health condition, and you're getting symptoms, then you may or may not be offered a blood test to take further the diagnosis. It really does depend individual by individual. So some questions to ask yourself during this period is around your periods and tracking those. Are they regular? Are they irregular? Are they heavy, light? Have they changed recently? And have you noticed any of your PMS-like symptoms in the run-up to your period changing? And of course, any of the other symptoms that we've talked about. I want to talk about the potential risks to health of the perimenopause and menopause, because we tend to think and hear a lot about the risks of treatment, and more of that in a minute. But it's true to say that there are long-term health problems which can arise from the perimenopause and menopause, essentially because beyond the menopause, we are in a significant hormone deficiency, and estrogen is a really important hormone for the body. And without it, we are at risk of a number of conditions, particularly osteoporosis, which is a condition that weakens our bones and makes them much more likely to break. Cardiovascular disease, which puts us more at risk of stroke, heart attacks, vascular dementia. And also other risks include type 2 diabetes, dementias, and some cancers. So menopause will lead to an accelerated inflammation in our body. Estrogen is an anti-inflammatory hormone. And so addressing that is really important. And we now know that for all-cause mortality, in other words, all cause of deaths, women who take HRT do live longer than women who don't, when we look at it at population level. And of course, notwithstanding any intervention we might make to replace the hormones we're no longer making, a healthy lifestyle is also really important to reduce these inflammatory conditions. Now, I mentioned fertility and contraception earlier, and I just want to cover this now. So we've got all this change and turmoil in our body, and assuming that we still want sex, and it is really important for a healthy lifestyle, then it's important not to forget about contraception, because although there is a natural decline in fertility with age and spontaneous pregnancy is rare after the age of 50, it can happen, it does happen, and contraception is still required until we reach that period of where we can say we're menopaused. In other words, 12 months after our last period. STI protection may still be required even after contraception isn't, so that's an important consideration if you're experiencing sex with new partners. Now, contraception doesn't alter the onset or duration of menopause. However, it might mask the symptoms and signs. So if you're using a hormonal method of contraception, or you have the coil in place, it is tricky just to know where you are in the process. The Mirena coil, which is the intrauterine device with it releases a little bit of progestogen locally. It can be used for contraception until the age of 55 if it's inserted after the age of 45, but it must be replaced every 5 years if being used for HRT. And we do use it for HRT to protect the uterus. Estrogen itself causes the uterus wall to thicken, and we need progestogen to combat that and to keep that thickening in check. So Mirena is a very effective way of doing it, and it has the added bonus of stopping periods, and particularly if you're heavy bleeding during that phase. Now, oral combined contraceptives, so these are the contraceptives that combine both estrogen and progestogens, should not be used over the age of 50, and lower if there are increased risks, for example, in obesity, smokers, etc. The progestogen-only pill and implant can be used alongside HRT, and we do see that. People, for example, who've got the implant can then go on to have HRT, but it's important to note that HRT itself doesn't provide contraceptive cover. The doses that we use in HRT of estrogen and progestogen are too low to give you contraception. Now, in general, a woman aged 55 or over doesn't require contraception. Pregnancy after that age, irrespective of where you are with your periods, is highly unlikely. A couple of other points just to mention: intrauterine contraceptives, so the Mirena, should be removed after their expiry date, if you like, in terms of once they're no longer being used for contraception or HRT, as they can become a focus of infection. And then the progestogen-only pill and implants are not licensed to cover you for endometrial protection during HRT. So we do need to get this combination of contraception and HRT right. So there are a vast number of treatments to help you manage your perimenopausal symptoms and vastly improve your quality of life in many cases. So the first step should be talking to a healthcare professional about the options available to you so that you can make an informed decision about the benefits and risks. And I would say don't wait until symptoms become unmanageable before you seek advice. And being informed like you are this evening can help you recognize the symptoms then when you may be perimenopausal, even if you're still having regular periods. Now, the most effective way of treating symptoms of the perimenopause is to supply your body with a steady dose of the hormones that are now in fluctuation and ultimately decline. So HRT usually involves estrogen replacement, and if you still have your womb, you'll need to take the progestogen as well, as I spoke about earlier. And it may be that you also benefit from taking testosterone in addition to estrogen and progestogen. If you don't have your womb, then you just need the estrogen and potentially add in testosterone. Now, HRT is most effective when it's started before the menopause, so the point at which our periods stop, or at least within 10 years of that. And that's in terms of giving you not just symptom relief, but also to give you the long-term health benefits. Now, there are other treatments that can be used alongside HRT, and for those women who can't or choose not to take HRT instead of, includes cognitive behavioural therapy, which is recommended by NICE as a treatment for low mood associated with menopause. There are other prescription medicines. We've already talked about the antidepressants, the SSRIs, such as citalopram, venlafaxine, which can improve hot flushes for some, but they do often have side effects, and they do tend to have an effect on libido as well. Herbal medicines. So some women, people consider taking herbal medicines alongside or instead of conventional medicines. This includes, for example, St. John's wort, red clover, black koshos, I can't say it. Anyway, herbal medicines are considered natural, but they're not necessarily safer. There are huge variations in their effectiveness and potency. Some come with side effects, and medicines such as St. John's wort can have a considerable impact on other medicines that you might be taking. And they won't address the cause of the symptoms. So your symptoms are being caused because of hormone fluctuations and hormone deficiency. And the only way to really address that is to replace those hormones, just in the same way that if you had a low thyroid function, we would give you thyroxine. If your pancreas wasn't working properly, we'd give you insulin. So that gives you some insight into treatments during this period. Healthy lifestyle as well can have a significant impact. Alcohol can have a very detrimental effect during the perimenopause and menopause, and many women actually find they just can't tolerate it at all. And we also know that drinking alcohol and being overweight can significantly increase the risk of cancers, particularly breast cancer. So I'm now going to come on to some other things that you can do during this important period. I've mentioned tracking already. Really understanding what's happening in your body throughout this period when it feels so much in flux can really help you feel in control. And there are a number of different ways to do this, including using trackers. Here in clinic, we use something called the Menopause Symptom Questionnaire, which helps us every time someone visits us to know how they're doing and whether their HRT, for example, is having an impact and whether there's anything we need to tweak. I would say trust your instincts about your own body. You know you. And if, for example, you're experiencing depression and anxiety for the first time or it's worsening, you will instinctively know you will feel it's your hormones or something's different to how you felt before. We can certainly look at background history as well. So reflect back on experiences you've had before, for example, before your periods or with postnatal depression. They can give a clue to how you're feeling during this period. Talk to a healthcare professional about options available for you. And as I said, doing that sooner rather than later is really important. There is no sort of special time that you have to wait to go on to HRT. As soon as you're experiencing symptoms and a perimenopausal diagnosis is made, you can go on to HRT, and there is no final length of time. You know, there isn't a time limit. The clock isn't ticking for how long you can be on HRT. So truly don't wait until the symptoms are unmanageable. And the larger the benefit to your long-term health, nor, provided you getting benefit from the HRT, is there a time limit to when you need to end. So there will be many women that continue their HRT through till the very end of life. So I want to touch on some lifestyle aspects just to sort of pull everything together. The key things that you would expect are good for our life generally, are good for us during the perimenopause and menopause. And it is a time in our lives when we can take stock to make sure midlife we're preparing ourselves for the very healthiest latter life that we can have. So exercise, good nutrition, a Mediterranean diet helps keep our weight under control, but also is good cardiovascularly and helps us to feel good and helps us with our gut health. Mindfulness, managing stress, making sure that we look after our bones with calcium and vitamin D, getting enough sleep, looking after our guts, as I've spoken about already, reducing those things that are going to derail us for all the efforts that we're putting in. So the alcohol, smoking, and making sure that we're screening. We're looking after our breasts, our cervixes, and we're noticing anything that's abnormal for us. We're getting our bowel cancer screens and tests when they come through the post, and we're noticing anything different so that we can get on top of those things sooner rather than later. And then finally, making sure that if we need contraception, we're managing that and looking after our sexual health as well. So keeping ourselves informed is a really important part of managing a healthy perimenopause into menopause. And there are loads of resources out there. We follow the practice of the Newson Health Clinic. The work that Louise Newson is doing is fantastic, particularly around her research and the guidelines that she provides practitioners such as myself and my colleague Sally. Really brilliant resources for patients and women. She runs the Balance website and app, and I would really suggest downloading the Balance app so that you can record and track your symptoms. And then there's a great little book written called Estrogen Matters, which can help, I think, reassure women going through this phase around the important role that estrogen plays as a very biologically active hormone across the whole of the body. So before we go on to looking at questions, I just want to summarize and say that there are more benefits to your health if you start HRT early. So don't wait for your symptoms to get worse. Don't suffer in silence. Don't feel that you're going to get some sort of medal at the end of all of this because you've done it without HRT. Remember that from a population health perspective, women who take HRT live longer than women who don't. The menopause means living with a long-term hormone deficiency, and if that's left untreated, it will increase your risk of significant disease, osteoporosis, cardiovascular disease, dementia, and diabetes, for example. There's no maximum length of time for which you can take HRT. HRT does not delay your menopause. If you have menopausal symptoms after stopping HRT, if you choose to come off it, then that means you would still be having symptoms even if you'd never taken the HRT. Now, as with everything in health, you are an individual. And so it's really important to recognize that, and deciding whether HRT is right for you or any other intervention, whatever that might be, depends on your individual circumstances and should be done in discussion with a healthcare professional who has an expertise in this area. And the benefit of any treatment needs to be balanced against the risks. If you want to find out more about HRT, our fourth webinar is going to be dedicated to HRT in detail. So with a few minutes remaining of this webinar this evening, I just want to hand it over to you to post any questions in the Q&A box. I do have a few that have been posted before, which I hope I've answered during the course of the webinar, but I will just run through them. A question was asked, will natural hormone tablets balance my hormones correctly? We will only use medicines that are licensed, or if we're using medicines off-label, for example, there is no licensed female testosterone in this country, then we use a licensed product from Australia for women. But there isn't a natural hormone tablet that is licensed in this country. We use hormone products, the licensed products that are body identical, so 17-beta estradiol that I mentioned earlier, and we use estrogen transdermally, which is the safest way to use estrogen and has no increased risk of blood clots. So if you're thinking that this is herbal products, then they won't replace the hormones. And remembering perimenopause and menopause is a hormone deficiency. A question was asked, will I still get hot flushes and sweats even though I'm taking herbal medicines? They may help you, but you won't, it's very likely you won't address the hot flushes and sweats associated with the hormonal fluctuations and deficiency of estrogen unless you replace your hormones appropriately. And the question was asked, will my anxiety reduce? Will my moods, will I still be irrational? Well, this is a symptom of the perimenopause and menopause and can be addressed on HRT. It's fair to say that it can take some tweaking to get the HRT right, back to the point that we're all individual. But we can generally get to a point where women feel like they've a different person, and we've got many anecdotes to that extent. I'm just going to whiz through some of the other questions that I've had posted, and I can see one's been posted onto the chat. Let's have a look at that first. So I've been asked, does having a C-section affect the onset of menopause in any way? Also, how good are the NHS in relation to diagnosing menopause? So, as far as I'm aware, a normal C-section will not affect the onset of menopause. If you've still got your uterus and you've still got your ovaries, then everything should be working appropriately. I'm not aware of any research on that. As far as the NHS in relation to diagnosing perimenopause, I think it very much depends on your practitioner. There are some fabulous GPs out there who are really getting clued up into the menopause, but there are also GPs who've had very little training in this area, and GPs have so much that they need to know about, and they get so little training on hormones that it may be that your GP hasn't got the confidence to prescribe and diagnose in this area. I've been asked what percentage of women usually are prescribed HRT. Well, it's still very low. I understand from recent data that it's only about 1 in 10 women. So it is still a reasonably low level. And I think we're still suffering, if that's the right word, from some now discredited evidence that was presented back in the early 2000s from the Women's Health Initiative, which misrepresented the risks associated with HRT. I've also got a comment here. I have symptoms of the perimenopause and will be contacting my doctor for blood tests. If needed, it is more likely to be prescribed HRT than not. Well, it depends on your age. If you're over 45, then blood tests are unnecessary. If you're under 45, between 40 and 45, you may find that the blood tests are inconclusive anyway. Our hormones are changing daily, weekly, monthly. It's really difficult. You may get a day the blood test is drawn and your FSH, which is what they're measuring, your follicle stimulating hormone, is low. And it usually is repeated after 4 to 6 weeks anyway. These tests are much more helpful although even then not perfect, in under 40s. I've been asked the question, does pregnancy after 40 impact on the menopause? And the answer to that is no. So, probably makes you feel tireder though, I would say, if you're managing a young child going into the perimenopause. I would imagine that's going to be quite a difficult period. So that's all the questions that have been posted. I want to thank you very much for joining me this evening. We've now come to our end. We will be sending out the recording to you. And if you've got any comments, then do let me know. Our next in the series include genital urinary syndrome of the menopause, which is quite a mouthful at this time of night, on the 7th of June. We're covering HRT on the 21st of June and testosterone specifically on the 5th of July. If you wish to book and have a conversation with myself or my colleague Sally, then you can use that QR code up in the corner. I'll leave that up for a moment. But if you just want to ring and have a chat or pop into the clinic if you're unsure about what next steps to take, then we'll happily have a chat with you and help navigate you through what can be a difficult time, but doesn't need to be. Thank you so much.